Okay, so good afternoon, everyone. I just got my ischemic preconditioning by taking a big cookie and eating it in about 15 seconds. So I got my hypertonic preconditioning anyway. I was actually very interested to see the earlier talk using the worms because I'm going to talk about fish. And so we'll have a continuum of species, some that eat others. So as Jim said, I'm a surgeon by trade. And what I want to talk about a little bit is remote ischemic conditioning and how it may apply beyond what we normally think, but rather in a traumatized patient. So, when people talk about disease, they're always talking about diseases like neurological diseases, cardiovascular diseases, diabetes. Very rarely are people actually talking about the impact of trauma, civilian trauma on society. But actually, when you look at a review of the impact, it's actually very impactful. It's number one in overall hospital days, number one in years of life lost, and that's predominantly because civilian trauma predominantly occurs in youth. It's number two overall in disability-adjusted quality life lost, and also number four overall in mortality. So it is a significant and important clinical problem. So I want to talk a little bit about trauma just by walking you through. And what I'd like to come away with in this slide is the fact that we talked a lot about ischemia reperfusion in the heart, and I think Andrew alluded to other organs. In fact, I guess one would say that trauma and hemorrhagic shock are really the mother of all ischemia reperfusion injury. Like every organ in the body sustains ischemia reperfusion. Hemorrhagic shock with resuscitation gives you ischemia and reperfusion in every one of the organs. And along with that, we know that ischemia reperfusion injury can induce oxidative stress, macrophage activation, and of course neutrophil activation. And the one thing that's unique about hemorrhagic shock is the fact that actually it can affect all the various organs related to across the body. So when you're talking about it in the context of remote ischemic conditioning, it's actually not a uni-organ effect that we might see, but perhaps multiple organs if it were indeed effective. So the one thing that we've learned about shock resuscitation in the trauma setting is actually there are two periods that are important. One is what's called the early period or the first phase, the shock followed by resuscitation. And then oftentimes what happens is that at the end of resuscitation, you don't have organ dysfunction at that time. What you have is a primed immune system so that a second hit like an infection or a GI bleed or something like that can lead to distant and later organ failure, which is a common cause of death in this patient population. But what's pretty clear is that if you can intervene during this period, at least in experimental models, that you can actually impact some of the events, not only at the end of resuscitation, but rather on organ failure. So it's very important to know that you've actually got in the trauma setting a little bit of time to induce your intervention, whatever the intervention is. So, of course, all of you in this audience know about remote ischemic preconditioning. I think Andrew gave a great review of it, but it's also a group of experts here. And I'd like to point out that when you look a lot of the literature in this, you look at it in the heart, liver, lungs, kidney, brains, intestine. Basically, ischemic preconditioning can prevent subsequent ischemia reperfusion injury in virtually all those organs and any time it's been looked at and well described. What's unique again about shock resuscitation is that all the organs are affected. And so the question is, would remote ischemic conditioning actually prevent some of that? And I'll show you some of our data that supports that notion. So what I'm going to talk about is three major areas. Number one, I'm going to overview the data that we recently reported looking at the protective effect of remote ischemic conditioning in a murine model of hemorrhagic shock. Number two, I'll talk about some of the potential mechanism of protection that we've studied in our model system. And of course, there are a lot of mechanisms, and we'll just have part of it. And then finally, I want to review with you a study where we're about halfway through a 2-year study period. We're actually doing it in trauma patients who come to our emergency room. So first of all, we, like everyone else, established a model for hemorrhagic shock. Basically, there's a pretty standard one where you take animals, you bleed them and bring their blood pressure down to 40 millimeters mercury for 60 minutes, then you resuscitate them, and then you follow them in the period after. What we did was we induced ischemic preconditioning in advance of that shock resuscitation. Our early studies actually did 10 minutes on, 10 minutes off, and then we initiated the shock. But now we actually have shown the same effects when we do basically what I think would probably be considered one of the standard clinical cycles, which is 5 on, 5 off times 4 overall. And we study liver and lungs, really looking at whether or not multiple organs can be protected. And this is the model that we used in some of our other studies that we use, like I told you. So I just want to give you a snapshot of some of the data in a paper we reported last year. In essence, this looks at the effect of remote ischemic conditioning in shock-induced liver injury. On the y-axis is the ALT, which is a marker of hepatocellular necrosis or breakdown of the hepatocyte. As you can see, at 1 hour and 2 hours after resuscitation, the liver releases an augmented amount of ALT into the bloodstream. The same is true for the other hepatocellular injury markers. And at both those time points, shock resuscitation with antecedent ischemic conditioning, preconditioning, actually is protective. If you look at the pathology, it's very telling. One of the early findings that you see in the liver is something called ballooning degeneration. And if you look at the upper right panel here, you can see rather than a pretty kind of homogeneous appearance, you get this bland appearance where you get large vacuoles in the hepatocytes. This is really pathognomonic of ballooning degeneration, which is one of the early findings. But importantly, in the lower left, you can see that that appearance of blandness is lost, and there's restoration of the normal hepatic architecture. And then when you quantitate it, you can see that using ischemic preconditioning actually is very effective in preventing liver injury if you do a blinded histological analysis. We're also interested in looking at inflammatory gene activation, and the two main ones that we focus on, and I think virtually everyone focuses on, at least as an early marker of inflammation, is tumor necrosis factor and interleukin-1. You can see again that shock resuscitation induces an elevation after several hours, and that's prevented with RIPC in both those circumstances. So it seems pretty clear that it is actually able to inhibit it. Interestingly, in addition to having effects in the liver itself, it actually had quite a profound effect on systemic inflammation. Here's systemic inflammation measured by tumor necrosis factor release. The majority of the TNF that's released comes from the liver, and you can see that it's elevated at 1 and 2 hours and totally abrogated in animals who've had remote ischemic preconditioning. So interestingly, we're wanting to look at other organs aside from the liver. So we took the lung, which is the second most common organ that's affected in shock resuscitation-induced organ injury. And you can see, as we saw in the liver, there's protection with RIPC at 1 and 2 hours. Here, looking at BAL, or bronchiolar alveolar lavage fluid, which is increased protein in the lavage fluid, is demonstrative of lung injury and leak of proteins from the bloodstream into the lung. You can see that RAPC prevented it under both those circumstances. And here, histologically, there's a neutrophilic infiltrate with thickening of the alveolar capillary membranes. Not totally prevented, but markedly reduced when you give antecedent RIPC. And when we measure neutrophil infiltration into the lung, which you do by basically churning up the liver and looking at lung and looking at myeloperoxidase, you can see that RIPC prevents that. And this is actually what initiated our interest in looking at neutrophil infiltration, which is one of the markers of organ inflammation. I didn't show you the data, but it was same true in the liver, and here the lung, showing that RIPC actually prevented induction of neutrophilia in the organ. Similarly, in the inflammatory cytokines, you can see that hemorrhagic shock markedly increased TNF elaboration in the lung, and that was again reduced here. So obviously, when you're thinking about using ischemic conditioning, remote ischemic conditioning in the trauma setting, one would probably argue that it's maybe a little different than having a bout of angina before you end up having a heart attack later on in the day. If you could predict that there was going to be a car accident that was going to happen, it might be very good. I guess if you had people who were in the military, potentially one might consider that this might be a preconditioning to mitigate the effects of subsequent shock resuscitation. But I think really the compelling question was whether or not the effects of remote ischemic preconditioning could be taken into the phase of either ischemia or reperfusion, either per or post-conditioning. And if you think of the scenario that you would see in the clinical situation, this would be highly relevant. So imagine a trauma victim at the roadside, the first responders coming, patient is already in shock at that point in time, and having the first responders able to actually initiate ischemic preconditioning, or now it would be ischemic perconditioning because they would be in the ischemia, and even into the resuscitation phase because that's what they do during the transport to the hospital. So we really asked the question whether or not we could extend the preconditioning into subsequent phases. And basically what we did was we extended our model, and this is the model that we used, again, the animal shock resuscitation model, preconditioning as I show you here with the 5 times 2 times 4, but either done starting in the end of the ischemia phase or even through the ischemia into the reperfusion phase, which would basically be post-conditioning. And interestingly, it was quite protective in both the per and the post-conditioning circumstance. And so let me show you that up above. You can see again the serum ALT increased in the controls. RIPC reduced it, but even in the per and the post period, you could see that there was a significant reduction compared to control. The same was true in the induction of inflammatory cytokines. You can see whether you give it in the preconditioning phase, in the per-conditioning phase, or in the post-conditioning phase, that in fact it was protective in the shock resuscitation model. And this is really the rationale that we used for the clinical trial that I'm going to show you towards the end of my presentation. So let's move back onto this again, and I want to talk to you a little bit about the neutrophil infiltration component of it. I showed you one slide where neutrophil migration into the lung was reduced by RIPC. I told you that in the liver there was a significant reduction in neutrophils. So what we proposed to do was to look at the potential role of RIPC on neutrophil migration. Now, Andrew made some very, I think, had a very comprehensive discussion of the effects of ischemic conditioning, remote ischemic conditioning on neutrophil function. I think it's pretty clear that if you take neutrophils from animals and from humans and you test them in vitro, that actually ischemic preconditioning or ischemic conditioning actually markedly reduces neutrophil function, reduces migration, reduces adhesion, reduces phagocytosis. Pretty clear in the in vitro model. And so what we proposed to do was to use a slightly different model to see whether or not we could look at it in vivo. And I don't know how many of you have tried to do neutrophil migration models in vivo in mice. They're not difficult, but they take a long time. They're expensive. So what we proposed to do was we proposed to move to a different model and basically proposed to the hypothesis that a soluble factor in the serum that was taken from animals that had undergone ischemic conditioning would actually be able to impair neutrophil function, in particular here, neutrophil migration. And we proposed that we would use a zebrafish model. So what you see here are two models. This is a model used by Dr. Renshaw that's now about a decade old. You can see this video. Basically, these zebrafish are transgenic zebrafish that have green fluorescent protein marking the neutrophils. And you can see basically in the bottom picture that this is a zebrafish, and under normal circumstances, not surprisingly, where the blood vessels are, you can see neutrophils throughout the body. However, if you cut off the tail and you do this under the microscope with a fine pipette, you can actually see that these neutrophils that start off fairly random over time tend to migrate into the tail. So this is a very good in vivo model to look at neutrophil migration into an injured area of the zebrafish. Turns out that the zebrafish has properties in its inflammatory cells that are very similar to human and murine neutrophils. So it's actually a pretty effective model for looking at neutrophil migration and function. So here's some of the summative data. On the left, you can see examples of a number of different studies. You can see at 6 hours after tail cut that the tails are actually chock full of neutrophils in the control animals. The way we induced RIPC in the zebrafish was not by putting a tourniquet around the tail. What we did was we actually took a mouse. We did ischemic preconditioning or ischemic conditioning on the hind limb. We took the serum from that animal. Then we took that serum and we actually injected into the cardinal vein of the zebrafish embryo, and then you wait several days for it to hatch. It takes about 24 hours overall to kind of get from the injection phase through to the point where they get to one where we can cut off the tail into the larvae. And it was at that time point where we actually tested for migration after tail cutting. And as you can see, controlled plasma caused a small but not significant reduction. But when you injected RIPC plasma into the zebrafish embryo, you could actually sustain that effect over about a day to a day and a half after and see that there's a significant reduction in the number of neutrophils that went into the tail. We did do some studies that characterized it. We certainly aren't a laboratory in which we do a lot of characterization of serum and proteins that are important. We're going to collaborate with people at Sick Children's Hospital, where Andrew Reddington worked before, to look at it, break it down a little bit more. We did a little bit more than dialysis. We did little more than dialysis, and basically we did a cutoff of 14 kD above or below. And you can see on the right, when we took the dialysis of the 14 kD that was less than 14 kD, no, this is greater than 14 kD, which is the control dialysis, there was no effect compared to control. When it was greater than 14 kD dialysis, you can see that there's a significant reduction. Compare that to using the molecular weight cutoff of 14 below 14 kD. So you can see that we concluded from this that it was something in the dialysis that was more than 14 kilodaltons that was important in inducing this anti-inflammatory effect, the anti-migration effect. So just to make a point, I think people who are working in the heart and do Langendorf models, I think almost uniformly, it's a small molecular weight molecule. So this is different. This is actually in the serum. It looks like it's a larger molecular molecule, and we haven't sorted this out yet, but obviously every single cytokine imaginable is over 14 kD. Mitochondrial DNA and clumps would be over 14 kD. So it's really difficult right now to tell exactly what it is, and we're going to do a little work on the characterization of that. But it does suggest the possibility that I think a point that he made to Dr. Downey was that if you take the Langendorf preparation and you look at RIPC under those circumstances and you compare that to the in vivo situation, oftentimes there's a greater protective effect in the in vivo situation. And this might suggest that different molecules are having different effects on the end organs, and that way may be why you get an additive effect in the circumstances where you're looking at the in vivo rather than simply the Langendorf. So, in summary, RIPC reduces liver and lung injury associated with hemorrhagic shock and resuscitation. The protection is associated with a reduction in inflammatory cytokines. We showed on our studies that per and post conditioning were both effective, which obviously have great clinical relevance, and that a molecule greater than 14 kD in the zebrafish model of migration of neutrophil to cut tail was the operative one that was important. So what I want to do is just spend the remaining time talking about some of the work that we're doing right now. I think, again, Dr. Downey really clearly discussed the role of reactive oxygen species, which are very clearly known to be produced by ischemia reperfusion. And we basically proposed the general hypothesis that basically, in response to reactive oxygen species, there was an induction of a panel of antioxidant genes. And we haven't done a comprehensive review of that, but I think probably the one that's best known among those is hemoxygenase 1, which in and of itself is not antioxidant, but can induce some antioxidant molecules. And in other studies of liver ischemia reperfusion, at least, hemoxygenase was shown to be important in the protective effect. So that was one of the hypotheses, and we asked the question whether or not in the shock resuscitation model was hemoxygenase important, and look at some of the factors that might be important. We hypothesized that an important transcription factor, NRF2, which is known to interact with the antioxidant response element of a number of genes that are antioxidant in nature, might be important. So here's some of the initial studies. So this is not published yet, but basically along the top you can see the Western blot showing hemoxygenase under control circumstances. Shock resuscitation very clearly increases it, and that's further augmented by the combination of shock resuscitation plus antecedent remote ischemic conditioning. It's also true when you look at the gene expression here of TNF and IL-1 on the right. So we also were interested in looking at the role of NRF2. So this is just a brief schematic of what NRF2 does. So again, NRF2 is a transcription factor. It is normally situated in the cytoplasm of the cell in response to stimuli that I'll talk about in a second. It might, whoops. Now I'm going to have to figure out how to go up one. It migrates into the nucleus. And once it migrates into the nucleus, it interacts with antioxidant response elements that induces a number of antioxidant detoxifying enzymes. So under normal circumstances, NRF2 is kept in the cytoplasm by its interaction with the molecule KEAP. And it's very well known that in response to reactive oxygen species, there's dissociation of KEAP from NRF2, and that allows NRF2 to migrate into the nucleus. And so we asked that question as to whether or not that might be important. And so first we measured NRF2 these are animal models, again in mice undergoing shock resuscitation. You can see that there's a small increase, barely visible. You can see on the right the summative data. But in response to the combination of RIPC plus shock resuscitation, you can see there's a significant increase. More notably, however, is the fact that in the nucleus, where you would expect the NRF2 to go, that increase is much more profound. So these data pretty clearly show that shock resuscitation with antecedent ischemic preconditioning actually augments NRF2 going into the nucleus of the cell. And we also did some immunoprecipitations to look at the association between KEAP and NRF2. You can see that under normal circumstances, just like in the schematic, NRF2 and KEAP are associated together. When you do RIPC alone, they're still associated. When you do shock resuscitation, which we know induces some degree of oxidative stress, there is a reduction in the association, but the combination of the two actually causes complete dissociation of the KEAP and the NRF2, findings that are really much consistent with the augmented migration of the NRF2 into the nucleus of the cell. These are studies that we're in the process of working on. So a lot of people have shown that basically when you do ischemic preconditioning that you get increased NRF2 and that there is increase in hemoxygenase. But actually in the in vivo setting, the idea that reducing NRF2 or preventing its upregulation could actually prevent the protection is one that actually requires testing. So what we did was we did this model in an NRF2 knockout animal. So these are our early studies, and it appears that they're consistent with that overall finding. So again, These are studies we did in animals. Shock resuscitation caused an increase in serum ALT, indicative of hepatocellular injury. That's prevented by antecedent shock resuscitation. Just as a control, we used an inhibitor of hemoxygenase, which was a protective molecule that we're postulating, and you can see that we lose that. So that's consistent with our findings that we had so far. So the three panels on the right are done in NRF2 knockout animals. So as you can see in NRF2 knockout animals, again, shock resuscitation causes the rise that you see in ALT. However, the protection that you saw in wild-type animals was no longer appreciated in the NRF2 knockout animals. In fact, at least in our initial studies, it appears as if there was an augmentation, something that is interesting, and obviously we're going to work on a little bit more. And then finally, I want to close with some discussion around the human trial. So we're a trauma center. We see about 700 traumas a year in our emergency room. Actually, it's not a huge number, but the vast majority of them are blunt trauma, and those are ones that are kind of oftentimes controllable hemorrhagic shock. And we proposed and are now performing a study where we wanted to determine the safety and efficacy of RIPC. Actually, obviously, because we couldn't start it till patients got to the hospital at this point in time, it was actually more RI per conditioning or even post-conditioning for the treatment of trauma patients. And we're studying two specific things. Number one, an inflammatory effect, because we know that shock resuscitation induces inflammation. But the other area we're interested was in coagulopathy. And I think Andrew did talk a little bit about endothelial cell activation and the induction of the coagulation cascade. But it's important to note that in trauma patients, the single most important cause of death is actually exsanguination, bleeding. So it was obviously very important to know whether or not RIPC was having a beneficial or adverse effect on coagulation, because that may be basically a game killer if it was causing more coagulopathy. So basically our hypothesis was that it had a beneficial effect on inflammation and coagulation. So here's our model. Basically, this is a randomized double-blinded study. We take trauma patients who come in from the field. They have to have had basically hemorrhagic shock or evidence of hemorrhagic shock with a systolic blood pressure below 90. We took patients within a 3-hour window of actually their injury, so that's the model that we have. We applied when they came into the emergency room either 4 cycles of ischemia reperfusion to the arm with an automated cuff. We used a cell aegis cuff. Basically, we did some size calculations on how many patients we would need. Remember, we're not looking for prevention of morbidity or mortality or even morbidity. We're actually just looking for a signal for the inflammatory effects of RIPC in this model. So basically, we're going to measure the immune inflammatory response, both the cytokine cascade as well as activation of neutrophils, which we think is important. We're also going to do something called ROTEM, which is rotational thromboelastometry. This is a test that you can do at the bedside in the trauma bay and look at basically coagulation in those patients, and so we'll be looking at that as well. So patients come in, they get we have a research person who comes day and night, 24/7. We actually have 28 research people who come one each day of the month, and basically they get randomized to one or the other group, and basically they go through the protocol. Obviously, RIPC done in the per circumstance in the trauma patient after they've had the injury with the hope that it will reduce sequelae and improve survival is our hope. And obviously this would be very applicable in the surgical setting, in the military setting. We have a really unique situation in Ontario where we have a scientist at our institution, Dr. Ori Rotstein, who actually has a very tight working relationship with the emergency medical services across the entire province. So we believe that if we see a signal from these kinds of studies, we'll actually be able to translate them to one that would probably be clinically relevant, where we could actually do RIPC at the scene or in the ambulance on the way to the hospital, and obviously include far many more patients. So thanks very much for the opportunity to give this short overview. My collaborators, one is Chris Calderon, who I think you might know, who has worked with Andrew a lot. So Andrew has worked on, he hasn't been directly involved in these, but obviously he and Chris work together. Zhao Yan Wen is a zebrafish biologist who works at our research institute, who actually is going to allow us to study mechanism, at least in more detail now that we have some leads on it. And this is the rest of our group. So thanks very much. Happy to take questions. Yeah. Right.
You can exsanguinate somebody, replace the blood with saline, and they will still live long enough for them to make blood cells. You put them in a hyperbaric chamber. You've got lots of hyperbaric chambers, also known as airplanes, that are sitting around and not flying. Why don't you get oxygen to these patients?
I don't know. I can't really comment on that, but getting a lot of patients into planes. Yeah, I think it's important to note that these patients are in extremis when they're seen at the site. So, basically any intervention that would interfere with their normal, basically transfer to trauma centers would probably impede their recovery. We know that one of the single most important factors in recovery after major trauma is actually getting to the trauma center in an expeditious fashion. So I'd like to think that this would be something that we could do on the way to the trauma center, because you have to stop the bleeding, and that's obviously paramount. I guess you could. Okay, well, so giving them hyperbaric oxygen?
Putting hyperbaric chambers in the back of the ambulances, developing that now with the fact that it was a longer period of time during their symptoms with those people.
Yeah, so I think that, this is one model to induce preconditioning, and I think that there are a lot of models to induce preconditioning. I know we're going to see a talk on hyperbaric preconditioning. So I think this is proof of concept on a very easy way, which is basically using a blood pressure cuff. I guess in our system and probably worldwide, putting hyperbaric oxygen in the back of ambulances might be a little bit of a barrier. But it may, in some, I think, circumstances, be a good thing. So, yep, Dr. Downing.
In the early phase of hypovolemia, you get a very intense vasoconstriction. Now, does that interfere with the efficacy of the remote to induce ischemia, and more importantly, to have reperfusion?
Yeah, so, that's what I thought. I was worried that this wouldn't work because the animals were in shock, and so you're not making it any less than what it is already by putting a tourniquet on. So we know for sure that there's definitely blood flow into the extremities of the animal, and we know for sure that in the humans there is actually blood flow. And so I think that it may be going from low to less with the reperfusion that might be valuable. Interesting you should ask that. There's one interesting study I came across where they used ischemic conditioning on patients who had ventricular fibrillation arrest, where they have very low, virtually no flow. And even in that patient population where there's no flow, if you do RIPC on them, you could actually improve their outcome, as evidenced by, I think troponins, but I can't recall the exact nature. Yeah. So that's another. So just think again. That's global shock, using ischemic conditioning as a means of improving outcome, and so in hospital that would be a kind of a clever thing to do. I think.
Maybe it's not flow.
Maybe it's not flow. That's right. Well, I think that the notion that part of the tourniquet could be related to the femoral nerve being stimulated would be consistent with that, for sure. Yes. Yeah, good question. So this is a pilot study that is in part related to understanding the feasibility of it. So at this point in time, we're not kind of screening people in or out. We have our inclusion criteria and a bunch of exclusion criteria that are obvious, but we actually will probably do a post hoc evaluation of comorbidities that might be quite relevant.
A follow-up, Bob Cloder just had a paper where he tried remote conditioning in a rat model, and he couldn't get any protection at all, but he included the femoral artery, didn't use the thumb.
You know, we actually did studies as well where we just did the artery because we had some criticism over the fact that we put the tourniquet on and we might get myocardial, not myocardial, but myositis and injury to the muscle. And actually, we were able to show in unpublished work that it was equally protective. But it was so tedious to do that compared to putting a tourniquet on, for sure.